My name is Dr. Alistair Baker. I'm a consultant in children's liver disease at King's College Hospital, where we specialize in liver disease, liver transplantation, small bowel transplantation, pancreatic diseases, and nutrition. Today I've been asked to speak on our experience and the world experience of post-transplant lymphoproliferative disease as a WebEx. I would like to thank my colleagues, Professor Dino Hadjic and Dr. John Salisbury for their contribution to this work and for some of their slides. Malignancies have been reported to be up to 50 times more frequent than in the general population. They were described from the very beginning of organ transplantation by the Pittsburgh group, and it soon became clear that they were the net result of complex effects of immunosuppression on the immune system and their effects on various cells, including natural killer cells and cytotoxic T lymphocytes. Another factor was the passive acquisition of various viruses during the process of transplantation, and there were parallels in the clinical phenotype and the immune responses, or absence of them, with congenital pediatric immune deficiencies, particularly with T-cell defects, and with AIDS. So the conclusion at that time that malignancies, particularly post-transplant malignancies and lymphoproliferative disease, were related to iatrogenic paresis of the immune system, resulting in an abnormal immune surveillance, impaired T-cell signaling and responses, and a disbalance in Th1 and Th2 lymphocyte function, which in turn resulted in uncontrolled lymphoproliferation. Post-transplant lymphoproliferative disease has had various reported prevalence, but is more frequent in children than adults. It is uncommon, but still more common in association with greater immunosuppression of heart and lung transplant and intestinal transplant, and in hematopoietic stem cell transplantation with HLA match is infrequent, but with T-cell depletion and greater T-cell related immunosuppression, it is considerably increased, illustrating the relationship between T-cell activity or appropriate activity and the likelihood of post-transplant lymphoproliferative disease. Viral involvement was recognized, as I mentioned, as being EBV-driven in terms of early onset post-transplant lymphoproliferative disease in children because there was increase in viral load and a decrease in EBV-specific cytotoxic T lymphocytes. But other viruses were also involved, and I'll return to this in a bit, particularly human herpes virus 8 and simian virus 40. So, on the other hand, the etiology of those post-transplant lymphoproliferative diseases that are EBV negative is less clear. Some may be due to EBV that's no longer detectable and perhaps has become incorporated in lymphocyte DNA, but is no longer demonstrable as viremia. HHV-8-associated PTLD, including post-transplant primary effusion lymphoma, is EBV negative. There may be unknown viruses, and it's been hypothesized that chronic antigenic stimulation, including antigens from the transplant itself, may contribute. Despite the fact that there's no evidence of EBV, at least in terms of viremia, EBV negative cases may still respond to decreased immunosuppression. Children, therefore, as recipients for transplants, are commonly EBV naive. EBV appears in or is evident in up to 80% of grafts, particularly those grafts donated from adults, and therefore EBV infection is acquired within about 3 months of transplantation, as I mentioned, often from an adult graft. Many liver transplant recipients remain EBV viremic for years with no obvious ill effects. However, in children after transplant, hypertrophy of lymphoid tissues generally, and tonsils perhaps most commonly, is seen with immunosuppression, and EBV may be associated sometimes with this. Early onset, PTLD is more likely to be EBV associated because of the early infection with EBV, but late onset, particularly after 1 year of age, 1 year after transplantation, is more often likely to be a non-Hodgkin's lymphoma subtype. So we can describe the clinical presentation of post-transplant lymphoproliferative disease with lymphadenopathy, often unexplained fever, sometimes graft dysfunction, but often the graft is relatively preserved, anemia, gastrointestinal bleeding, FOB positivity, hypoalbuminemia, perhaps bone marrow depression if it's severe enough, and perhaps hemolysis. The EBV PCR is typically positive, but as mentioned before, not always. And this is associated with EBV VCA IgM positivity, raised lactate dehydrogenase, perhaps polyclonal hypergammaglobulinemia, positive fecal occult blood in stool, and hypochromic microcytic anemia. Here we have a CT scan of a child with just such a phenotype, with FOB positivity and fever and lymphadenopathy, showing fairly extensive retroperitoneal and mesenteric lymphadenopathy compatible with a PTLD, which in fact the child did have. And here we have other typical localization with lymph nodes, cervical in the neck, lungs and liver being other common sites. But it can occur almost anywhere. Central nervous system disease is uncommon, either as the only site or in association with multi-organ involvement. In either case, it's rare, but it can involve the allograft in solid organ transplantation recipients, rarely in the liver, and may even more rarely be associated with rejection and infections, making a very difficult situation to manage of rejection versus controlling PTLD. The understanding of primary infection of EBV describes how EBV penetrates mucosal membranes, or in the case of transplants, is introduced with the transplanted organ. The virus enters B cells, and in doing so, it effectively immortalizes the cells. And although some cells are attacked by cytotoxic T cells with lysis, others become immortalized and display these LMP1 and LMP2 markers, which result in latent infection and resting memory B cells. These in turn may proliferate, and if they are not attacked by cytotoxic T cells, become a lymphoproliferative clone or series of clones, which is the early PTLD. In the normal situation of immunity, there is adequate cytotoxic T cell response, resulting in controlled or absent viremia, but small amounts of virus infecting cells in the mucosa or epithelium, resulting in salivary EBV, which can go on to infect other people. It's only those clones of EBV carrying and LMP1 and LMP2 protected cells, which can thereafter proliferate in polyclones or single clones to produce a PTLD. These latent membrane proteins, LMP1 and LMP2, are variously anti-apoptotic, resulting in long-lasting or even immortalized cells. They signal growth and the predisposition towards proliferation and regulating their own growth or failing to do so, and have an oncogene product. They can block tyrosine kinase and maintain latency of clones of EBV-infected cells. So these clones tend to lead to risk of proliferation and ultimately malignant behavior. So we know from experience that a proportion of these PTLDs will respond well to the withdrawal of immunosuppression. They also exhibit, as I'll describe later, anti-CD20 B-cell monoclonal markers and respond therefore to rituximab. Occasionally, chemotherapy is required, which is usually cyclophosphamide, vinblastine, and prednisolone. Occasionally, localized or CNS disease requires radiotherapy, and very occasionally, local surgery is required. But however, antivirals such as ganciclovir and acyclovir, valganciclovir, have no place in the treatment of post-transplant lymphoproliferative disease. Rituximab is now really the mainstay of managing PTLD alongside reduction of immunosuppression or discontinuation. It's well tolerated. It's effective in other non-EBV driven lymphomas. However, it doesn't pass the blood-brain barrier, so it's not helpful for CNS PTLD, but it has some potential to treat autoimmune disorders in other contexts. However, its treatment with this product leaves transient functional failure of antibody production, requiring prophylaxis with antibodies and cotrimoxazole for a matter of months or longer. Its role in prophylaxis is unclear. However, we have used it in circumstances where patients have EBV viremia and require intensification of immunosuppression because of severe rejection with EBV viremia, and that seems to have worked well. A relatively newer and experimental treatment is adoptive immunity transfer using cytotoxic T lymphocytes, which are infused. They're prepared specially from EBV-sensitized cytotoxic lymphocytes, which are immortalized and stored or banked ready for use and matched when patients have PTLD requiring treatment, which usually would not have responded to rituximab. We recognize some risk factors for adverse outcomes for PTLD, including multiple sites of disease, although the application of this principle to children is less clear. Multiple sites in the GI tract, for example, probably could be considered a single site. Advanced stage or stage of disease, and stage of, particularly in terms of histology, suggests an adverse prognosis. Central nervous system or bone marrow involvement are associated with a worse outcome, particularly if the CNS disease is destructive. Older patients at diagnosis tend to do less well. But highly elevated lactate dehydrogenase suggests a highly active condition. Hypoalbuminemia, possibly due to general level of unwellness, and those lesions which are EBV negative, or at least are not associated with EBV viremia, tend to behave more aggressively. Historically, mortality rates were quoted as 25 to 60%, which no longer apply. Newer therapeutic strategies are associated with a better outcome, and now it's reckoned that mortality is of the order of 2 to 10%, depending on other factors. Non-destructive PTLDs tend to regress with reduction in immunosuppression, and if this can be accomplished without immunosuppression, the prognosis is excellent, especially in children, so they may not require further treatment beyond reduction of immunosuppression. The concept of non-destructive PTLDs I will return to later on. Some infectious mononucleus PTLDs are fatal, including those which are fulminant, and I'll touch on those kinds of cases which are seen infrequently. Polyclonal PTLDs and even some monoclonal PTLDs may regress with the reduction in immunosuppression, as I alluded to before, and some polyclonal PTLDs and most monoclonal PTLDs will require at least rituximab, and some require COP, chemotherapy as well. Surgical excision and radiotherapy are required for localized cases and CNS disease, but this is uncommon. I have some local results which may be of interest. We've audited our own service care of PTLD on 2 occasions. The first data came from the period 1990 to 2007, which included 24 patients, which is 3.7% of the total transplant population during that period. 14 of these had chemotherapy, and we had 75% survival. And amongst the survivors were 2 children with long-term remission completely off immunosuppression, as described by Nast et al. With this high level of IL-10-mediated mechanism of graft prevention of rejection. The risk factors for developing PTLD amongst this cohort were primary EBV infection during or immediately after, early after transplantation, past immunoablative chemotherapy or treatment with ATG or OKT3, and cumulative total immunosuppression during the total prior period before developing PTLD. A second audit considered 36 patients from year 2000-2017, so you can see that some patients got into both studies. We found that the median age was 1 year of age. The post-transplant proliferative disease was usually or most frequently diagnosed in the 4th year. The follow-up for this group was 2 years or just over, and our survival both at 5 and 10 years was 86.3%, which is 11% better than in the earlier cohort. 92% of these total patients had EBV infection. Lymphadenopathy was the presenting sign in 2/3, but gastrointestinal involvement was seen in well over half. And we had 4 cases of fulminant PTLD who died. So what we found was that GI presenting disease tends to be milder. The histological subgroup was more likely to be non-destructive PTLD if we had endoscopic diagnosis. Patients diagnosed by endoscopy tended to have blood in the stool at presentation, which was an early warning to prompt endoscopy. Chemotherapy for those diagnosed by endoscopy was uncommon, whereas those who were diagnosed by other means were more than half requiring chemotherapy, and no patient diagnosed by endoscopy died. I thought it would be worth considering PTLD classification. It's recognized that the underlying causes of these neoplasms is unknown and can vary. But it's really important that since we all have to work together as histopathologists, clinicians, and virologists to treat individual patients and groups of patients, it's important that we understand each other and we have a classification that allows us to think in the same terms of the treatment. And although pathologists must take primary responsibility for developing a classification, the involvement of all clinicians is essential. The World Health Organization classification of PTLD, 4th edition, applied until 2017, and was a collaborative project of the European Association of Histopathologists and the Society for Hematopathology, and it was ensured to be clinically useful. However, time and the types of investigations which were becoming in use changed the nature of the information we needed for classification, and therefore the 4th edition was revised in 2017. This is on one level helpful to have this revision, but they're both called 4th edition, and sometimes there's a lack of clarity about that. And the revised 4th edition from 2017 is the one that everybody is now using. And amongst those reclassification criteria, probably an important one was the idea of reclassifying from early lesions to non-destructive lesions. The idea of early lesions is that they present early, of course, but that's not always true. Some destructive lesions present early, not the majority, but then some non-destructive lesions are not early. So the term non-destructive lesions has superseded early lesions. The classification, therefore, in histological terms, in degree of increasing aggression of the lesion, starts with a plasmacytic hyperplasia, proceeding through infectious mononucleosis, florid follicular hyperplasia, polymorphic PTLD, monomorphic PTLDs, B and T stroke NK cell types, so not all PTLDs are B cell types, and then classical Hodgkin's lymphoma PTLD, requiring typically increasing intensity of immunosuppression withdrawal, rituximab, chemotherapy, and other treatment. The commonest group in our experience and internationally, it tends to be monomorphic B-cell PTLDs, which are more than half of all PTLDs. And I think that this illustrates the value of tissue diagnosis. Despite their name, not all are completely monotonous or and monomorphic, fully monomorphic. There can be pleomorphism of the transformed cells, some plasmacytic differentiation, occasional Reed-Sternberg-like cells. There can be areas of geographical necrosis. The cells are variably EBV positive. Usually some are, but not necessarily all or the majority. Cells mark with CD20, CD79A, or CD138. There are often CD30 positive cells, but these tumors usually respond well to rituximab. So can we prevent PTLD? In our own institution, we have undertaken prospective monitoring of EBV viremia within the first year after liver transplant, following that only with graft dysfunction or on increasing to greater immunosuppression to manage graft dysfunction with rejection. If the EBV PCR increases by usually more than 1 log level, we've reduced the tacrolimus levels by 10 to 20%. We have had some success with that and keeping EBV lower and PTLD less frequent, although our data is a bit unclear. Data that we have suggests high sensitivity for the level of EBV viremia for the development of PTLD, but low specificity. In other words, there are many patients who have very high EBV viremia for a long period of time and seem not to develop PTLD. This seems to be different in children to adults. So in conclusion, PTLD appears to be relatively unchanged in incidence among transplant patients and groups. And that's despite more potent immunosuppression, but probably because of better awareness and modification of immunosuppression. The mortality of PTLD is reducing, so that it is only perhaps 2 to 5%, maybe a little more in those patients who are severely immunosuppressed or have other morbidities. The predictors of PTLD are a combination of high EBV load and depletion of EBV-specific CTLs. We have a potential model to help understanding the pathogenesis of other lymphomas through the relationship between viruses and T-cell function and the development of lymphomas. There is a model within this, including with IL-10, for studying post-transplant tolerance, and we still await an EBV vaccine. Thank you for your attention.